Let me just text the Russian friends.
Sergio, I'm in English, yes?
Well, if you want to try Russian, but I think
no,
will be extremely limited.
Thank you.
But you could impress us.
Hi, Vasila.
Hi, Oscar. Nice to meet you.
So we have Cleopatra, Queen Pauline with us. You are going live, girls, or are you going recorded?
We are ready for if there is any technical inconvenience, so I'm ready for live. You have my recorded videos in case.
Yes, everything is here, and it's 1 p.m. Italian time. So Eugene, I know it must be a very good lunch, but it's time to get started, I guess.
Hello, everybody. Thank you very much for allowing me to attend.
Hi, Makoto. Thank you so much for being here. And Jin-song, can you hear us nicely?
Yes, I can hear you very clearly.
It's wonderful, thank you. And we have also Takashi, see. Ciao, Takashi, all good there?
Yes.
Yes. Are you sharing your slide, Takashi?
Sorry?
You're going live with your talk,
yes,
right?
Yes.
Yes, that's great. So, Eugene.
Takashi, thank you very much for taking part of me.
You're a great synergy. So let me just call Eugene. Okay. Here we are. Because I cannot share my screen, technical team, please. So I think we should stop sharing the slide and allowing us sharing so we can get started. Or they really want it to be Italian academic style. We always have 15 minutes that is considered academic. Here we are. Eugene, can you hear us? Looks like no.
Hello, how are you?
Who is this? Who was talking?
Jamie, no?
Yes.
Oh, we have Rodrigo with us. Yeah. Ciao, Rodrigo.
How are you?
Nice to see you, and we hear you perfectly. We are missing Alvaro.
Yeah. A pleasure. Thank you for joining me, and thank you for your invitation.
Thanks to you. And we are guests of Eugene today.
Preparing all the meetings. Okay?
So we have to thank the Russians, friends, and in particular Eugene for the invitation.
Perfect.
I don't know if you have ever attended the live meeting, Rodrigo, in St. Petersburg. It's a wonderful Christmas meeting that they've been doing for many years now. Really nice, a little bit cold, but wonderful atmosphere and hot as atmosphere. So I think Eugene will give us the go. Maybe they are not listening to us because we are in the interpretation channel. Let me see. Eugene, can you hear us? No. Let me send again a text. I think they cannot see us. They are maybe not connected yet because they see that in the monitor, they don't have us. So we should see ourselves on the back of Eugene.
My dear friend, dear colleagues, I'm glad to see you here in St. Petersburg. In the winter St. Petersburg. Many years ago, we organized the first St. Petersbourg Venous Forum, and our friend Boeklov helped us to organize it. And many years later, we organized European Venous Forum, and it was improve. And in 2015, European Venous Forum was more than 800 participants from all continents and from many, many countries. And last year, St. Petersburg Venous Forum was 850 participants with 35 countries, and St. Petersburg Venous Forum became an international Venous Forum. I'm glad to see all of you, all participants, all lecturers, all discutants from the different countries, all my friends, the leaders of world phlebology here in Winter St. Petersburg. Welcome, my dear friends. Let me to start the section St. Petersburg Venous Forum and the Wien Foundation with Sergio Giannezzini.
Thank you so much. Thank you so much, Eugene. Please confirm you can hear me. Yes.
Yeah.
So thank you so much for the invitation. Thank you to all the world who has joined us today. And particularly thank you to the wonderful faculty that is making this session possible. The vision of this session is to have key opinion leaders from all around the world, with the key opinion leaders particularly from Russia, involved in a one-to-one ratio with the international guests. Indeed, we are all guests, me included, of Professor Shaidakov, that on behalf of all the Wien Foundation and all of our colleagues and friends, we'd like to deeply thank for this initiative. And now we pass the mic to Oscar for the Wien Foundation auspices. Oscar?
Thank you, Sergio. Welcome, everybody. First of all, I want to thank Eugenie and the organization of St. Petersburg Venous Forum for having opened the doors of their homes and allowing us to exchange scientific aspects of our much loved specialty, generating a true scientific and educational bridge with the participation of referents from all continents. Thank you, Sergio.
Thank you so much. And now the opening all the way from Egypt in honor of the recent LATAF project that connected Latin America and Africa. So our dear Professor Wasila Taha, our Cleopatra of phlebology.
Thank you so much, Sergio. I cannot take the floor without congratulate you for the vision also for the session. It's a bright idea for the insights of similarities and controversies for the global guidelines. And on the name of IVLA, Egypt Africa Vein Lymph Association, delightfully integrated with LATAF educational initiatives between our dear friends from LATAM Different Society. I'm deeply thankful for the kind invitation from the Wien Foundation, now family, Professor Giannezzini, Professor Chi, Professor Bozzini, and surely extending our deep thanks to St. Petersburg Venous Forum President, Professor Shaidakov. Wishing you all the success and Merry Christmas for all of you. Hope that the new year brings much brighter time. Thank you very much.
Thank you so much. And last auspices, but not least, because huge indeed, it is Professor Raymond Martinbeau, all the way from Canada. Pauline, are you with us?
Yes, thank you, Sergio. I always dream to go to Russia, and I'm very happy to listen today at the significant progress with several innovations that the field of phlebology has made in recent years. However, there appears to be a growing gap between research and clinical practice, and current guidelines are generally not always based on robust evidence. The majority of recommendations are based on expert opinions, consensus, or case studies. But today, another aspect of our discussion should not ignore that we have indeed entered the era of collaborative decision-making with our patients that is complex and requires attention. I look forward to listening to the presentations of a multidisciplinary vein team that should aim to evaluate the proposed solutions to determine the appropriate, safe, and effective therapy for an individual patient. Spasiba, Evgeny, for inviting me to be part of this webinar, and I wish everybody a wonderful and exceptional experience today.
Thank you so much.
Thank you.
Thank you so much, Pauline. And now let's get started with the scientific part. And we start huge with Professor Takashi Yamaki from Tokyo Women's University. All the program is basically looking at guidelines, similarities, and controversies from all around the world. This has been a topic we touched last year with the BWIN Foundation. It's really time to gather together to have more homogeneous recommendations, of course, with the respect also of the different nationalities' needs. And we will always have two huge figures, always one from Russia and always one from another continent. So I deeply thank, again, the Russian colleagues. We will now enjoy similarities and controversies in global guidelines on sclerotherapy, passing the mic to Professor Takashi Yamaki, and then we will enjoy the continental experts. Takashi, the mic is for you, if you want to share your screen and start your talk.
Thank you. Thank you for your kind introduction. I will start my presentation.
Perfect, we can see it. You can go.
Okay.
If you're playing a video, Takashi, we cannot hear it. So you should use the PowerPoint presentation. Otherwise, I have your presentation ready and I will share it. So I will share your video, okay? Okay, Takashi?
Okay.
Okay, I will share from my side, don't worry. Just please confirm you can hear it.
Thank you for your kind introduction. It's my honor to be here to give a talk on sclerotherapy. Nowadays, we already have many existing guidelines on foam sclerotherapy available from continent to continent. Most guidelines were published after 2011, and the latest one was published in 2016. This slide shows the indications for sclerotherapy. Most guidelines are quite similar in terms of the indication. The only major difference is noticed between European and Latin American guideline. Latin American document is 2 years more recent than European one. The indication to sclerotherapy for incontinence saphenous trunk was downgraded from 1A to 1B, while the indication to perforating vein treatment was downgraded from 1B to 2C. Another discrepancy indicated among the guidelines was maximum foam volume per session, 10 ml for the European guidelines and 20 ml for the Australian guidelines. European guidelines, however, allow volume greater than 10 ml according to the risk-benefit ratio. If you look at the absolute contraindications, a lack of uniformity is found in the different guidelines. For example, India and the American Society for Dermatologic Surgery document consider acute superficial vein thrombosis as an absolute contraindication, while the European and Australian documents considered it as a relative contraindication. The American guideline is the only one considering a superficial vein thrombosis as a relative contraindication and a deep vein thrombosis and/or pulmonary embolism associated with a previous sclerotherapy treatment as an absolute contraindication. Concerning the severe complications, general agreement is found among different guidelines. NICE, the American Society for Dermatologic Surgery, and the European guidelines are the only ones reporting the incidence of complications with different value. The significant heterogeneity among international guidelines is found on the post-sclerotherapy calibration. The rate of evidence varies from lack of proper scientific data declared by NICE to the 1A recommendation of the Latin American guidelines. The pressure value range from 16 to 14 mmHg according to some guidelines, while NICE, European, and Latin American guidelines are not reporting specific pressure value. The duration also varies from 24 hours to 3 weeks, indicating that choice should be based on the best critical judgment due to the lack of evidence on this topic. Currently, polidocanol foam in various concentrations is approved in many countries, including Australia, France, Germany, Italy, Japan, and the United Kingdom. In these countries, sclerotherapy has been performed using physician-compounded polidocanol foam, which is generated by a double-seam system or tesserae method. In contrast, only commercially prepared polidocanol and venous microfoam is approved in the United States, which is homogeneous foam comprised of 1% polidocanol liquid and a combination of O2 and CO2 as a forming gas with a liquid gas ratio of 1:7. In the comparative study, bubble size and size distribution were analyzed between 1% physician-compounded polidocanol foam and polidocanol and venous foam. You can see that physician-compounded foams made with the tesserae method had broader bubble size distribution and larger bubbles, which have an impact on foam stability. In contrast, polidocanol and venous microfoam had a lower degradation rate rather than any physician-compounded foams. The same result was obtained at different liquid-to-gas ratios for physician-compounded foams. In the biomimetic Bay model, polidocanol and venous microfoam had the slowest degradation rate and longest cannulated dwell time, which represents the length of time the foam is in contact with the vein, almost twice that the physician-compounded foams using room air and 8 times better than physician-compounded foams prepared using equivalent gas mixtures. Therefore, authors concluded that polidocanol and venous foam had better overall performance than physician-compounded polidocanol foam. However, the comparison was done against a placebo and with only 1% concentration. The superiority of the polidocanol and venous microfoam over physician-compounded foam prepared at various concentrations is still unknown. So in conclusions, maximum amount of sclerosing volume per session appear to be variable among countries. Post-sclerotherapy compression is generally recommended in the different guidelines, but with significant heterogeneity in the rate of evidence, dose, and duration. Some differences can be noticed among the international guidelines list of the possible complications and contraindications, and compounded foam sclerotherapy can be standardized and reproducible in its production, but it requires standardized methodology and materials. Thank you very much.
We deeply thank Professor Takashi Yamaki. Eugene, it's time now to introduce our key opinion leaders, and in particular the one from Russia.
Thank you very much, Sergio. Let me introduce Sergei Belentsov from Yekaterinburg, one of the leaders of phlebology in Russia. Please, Sergei.
Can you hear me? Yes. My question is about elastic compression. Dear Takashi, do you think how long our patients should use compression stockings after the sclerotherapy, in your opinion?
I think, Eugene, we have to repeat the question because I'm not sure Takashi heard it. Takashi, did you listen to it? You have to
No.
So wait a second, because the information for the ones who are online is that when they are speaking from the floor, you want to go off, because we want to say to the translator that if the speaker is speaking in English, we are not hearing him. So you have to go off in the channel if you want to listen to him. Can you please repeat the question, Professor Benenstoff?
Yes. The question is about elastic compression. Dear Takashi, do you think how long patients should use elastic stockings after the sclerotherapy, in your opinion?
Thank you so much. Takashi, were you able to hear this?
I'm applying compression stockings for 1 month after foam sclerotherapy.
Did you?
Just 1 month.
Did you hear the question from the floor? Did you hear the answer from the floor? What was the answer heard, Eugene, from the floor?
Yes, it's okay.
Yes.
Oh, okay. I think it is a very interesting question, because in reality, it has been shown in the document Professor Takashi was presenting that there is a huge range in terms of prescription, with countries who are going 24 hours and other countries that are going all the way to 4 weeks, with pressure that are ranging from 16 on the way to 40 millimeter mercury. And we have, at the end of this session, Professor Luri, who is, of course, one of the biggest experts on the topic, so we look forward for his comment on this. Now it's my pleasure to introduce the next key opinion leader on the way from Peru, a dear friend, Professor Joan Chunga. Joan?
Thank you, Sergio. Thank you, Professor Shayako, for the invitation. Dear Professor Yamaki, you have very well shown that sclerotherapy is a safe procedure, even though it's not standardized. My question is, in your opinion, how important is to use a foam that has the slowest degradation rate and the longest calculated dwell time, assuming that this means the more time of foam in contact with the vein? If we know that bubbles are deactivated within seconds after being injected, from the papers from Professor Tesari and Parsi, and also considering that we perform the injection just a few seconds after we have prepared it, do you think this will be cost-benefit worth it?
Thank you, Dr. Chunga, for your question. I really appreciate your excellent question. Yes, the slowest degradation rate and longest calculated dwell time means more time when foam in contact with the vein. The comparative study between physician compounded polydocanol foam and polydocanol and venous foam showed that the length of time of the foam is in contact with the vein almost twice that of physician compounded foams using air foam, and 8 times better than physician compounded foams prepared using equivalent gas mixtures. But as you stated, foam will be deactivated by a relatively small volume of blood. Therefore, I believe that length of the time of foam in contact with the vein does not always predict the better outcome. To improve the efficacy of sclerotherapy, I think it's necessary to reduce the blood volume in larger veins and to introduce fresh aliquots of sclerosant along the length of the vein. So in my practice, varices are treated with multiple injections with a small amount of foam rather than a single injection with a large amount of foam. In my previous study published in the European Journal of Vascular and Vascular Surgery, multiple injections with a small amount of foam provided probes to reduce the chance of foam to migrate into the venous system. Thank you for your question.
Thank you so much, Professor Takashi Yamaki, to Professor Benstoff and Professor Chunga. We now move to the other pillar, that is, of course, the one of compression, with another dear friend and a huge professional figure, Professor Santiago Fabricio, on the way from Brazil. I will play his video, and then we will enjoy the discussion. Please confirm you can hear it.
Hello, everybody. My name is Fabrício Santiago. I'm a Brazilian vascular surgeon, and I'm here to talk to you about the comparison between the TEM and international guidelines on graduated compression. I have no disclosures for this presentation, and I'd like to thank the organizing committee and the Viewing Foundation for the nice invitation. So this is the guideline that was published in 2016, and these are the same topics that we're going to use here, the topics that were used on Global Guidelines, Trends and Controversies, published in 2019, that were venous symptoms and signs control, ulcer healing and recurrence, post-procedural indications, venous thrombosis, long-distance flight, and pregnancy, all of them for graduated compression. I want to call your attention for these highlights that we're going to see during the presentation. When you see a red bar, this is something that we need to reflect about it, not so positive aspects. And if you see this green bar, it means that we have some interesting points. So start from the beginning. The guideline was published only on Spanish language. This is very good because it's a Latin American guideline, but it gives access to Latin American colleagues that are not familiarized with the English language. But on the other hand, it does not give access to colleagues all around the world that are not familiar or to write or to read the Spanish language. So this is something that probably should do in both languages. For venous symptoms and signs control, we do not see any recommendation gradings in this guideline and also no quality of evidence analysis. But we have some very interesting situation that was the indication of graduated compression according to clinical seat class. As we can see here, we can see that for low seat classes, the indication, most of the indications are for low compression, along with eccentric compression if sclerotherapy is performed. And for symptomatic patients, we can increase the indication of graduated compression for 20 to 30 millimeters in mercury, but for veins above 6 millimeters, that should not be considered reticular veins, but it should be considered varicose veins. So for C2, there are indications for use graduated compression for maintenance treatment only. So they are indicating the initial treatment with bandages only, and only for maintenance the use of graduated compression. The same thing for C3, depending on the grade of induration or the edema, 30 to 4 millimeters in mercury are indicated. Same thing for C4, same thing for C6, C5, and C6 only for maintenance treatment. The initial treatment should be done with bandages. For ulcer healing recurrence, again, no recommendation grading or quality of evidence analysis for graduated compression, but they have an indication and a very good analysis of the importance of the compression modality. It doesn't matter, they are not addressing the type of compression that should be used, with a high recommendation grading, with moderate level of evidence for primary therapy for ulcer healing, and with a high level of high recommendation grading and good level of evidence to avoid recurrence. For post-procedural indications, again, no recommendation grading or quality of evidence analysis, but they are recommending the use of eccentric compression along with the graduated compression. And this is seen also in European 2018 and in AVF 2019, of course, with different recommendation gradings. As we can see here, 1B for 2018 European and 2B, 2C in AVF 2019, but both of them are indicating the use of eccentric compression post-procedural. For venous thrombosis, that nothing was addressed, not for long distance flights, and again, not for pregnancy. So this is something very interesting that we could not see the recommendation grades and level of evidence analysis during the Latin guideline. But in other chapters, we could see that this was done, and this should be done also for graduated compression. As we can see here, for small saphenous vein treatment, good recommendation gradings with different levels of evidence according to CHEST methodology. This is very important because from global guidelines, we could see that we have different recommendation gradings with different scientific backgrounds from different guidelines for post-operative compression. This is something that we need to study and to analyze. Why is that happening? So I'm finishing my presentation by giving you a phrase that was done at the beginning of the guideline. It was a very good phrase where the authors states that although we recognize the guidelines of the world's leading countries as valid, our problem means that the practice is in many cases adapted to our possibilities. So to adapt to our possibilities, this is something that is very nice and we really need to do. And I'm mentioning here the example of some appraisal of guidelines. This is the AGREE method that is one of the best methods that was analyzed according to one of the PLOS One publications, where we can see that a good guideline should address the views and the preferences of the target population and the advice and tools to be put into practice, and again, potential resource implications of applying these recommendations. I would like to thank you, Professor Shaidakov, for being with us here last year in our local meeting, even if it was at a distance, but he gave us a very nice presentation. And I'm eager to see you all in person so that we can exchange information and exchange knowledge. Thank you very much.
And thank you so much to Professor Santiago, who is here with us live. So Professor Shaidakov, if you want to introduce us to the key opinion leaders from Russia.
My pleasure to introduce Professor Shiglov Ernest from Petersbourg University from Russian Karelia. Please, Ernest.
Dear friends, I am honored to participate in this session. Fabrice has made very interesting information about comparing the different recommendations, different countries devoted to the problem of grouse stocking use. As all of us speak, we must have the same scientific view, but different points of view might also exist. The use of grout compression stockings for a long time was mandatory in different situations, but now we have some different investigations which give rise to doubt. For example, the use of grout compression stockings after the sclerotherapy is one of the problems. All of us must follow the world trends in such situation. And we must understand that guidelines must only guide us, but the best solution for one patient in one situation is not the best for another one in another situation. Nothing will replace the common sense in practical decision. And I have one question to Fabrizio. What do you think is better, to have the recommendation for the whole world, the recommendation for which will be used the whole world, or we have the same recommendation for each country or each region?
Professor Santiago,
can you hear me?
Yes, perfectly.
So this was a total appropriate comment. I thank you for this comment, and I thank you for this question. And from a strict point of view, from a scientific perspective point of view, we need to make a difference between a consensus and a guideline. Often consensus, they are based on expert opinions and personal opinions. They are very good, and usually they are adapted to the local reality. And the guidelines should be addressing the scientific background about it, although they also should state what is the best situation for the local problem. As an example here, I'm in a low-income country under development. I have a situation on my private practice that is totally different from the my public activities in the public health system. So we need to totally adapt. But it's my mission to give my residents the information what is the best about the scientific background. I totally agree with you that guidelines should be adapted to the local situation, and guidelines should address that on their comments or on their statements.
Thank you so much, Fabricio. Now it's my huge honor to introduce a wonderful person and a great professional, Professor Zaza Lazarashvili from Georgia. Zaza, Salvatore, if you're here. Zaza? Yes.
Thank you very much, Sergio. First of all, I want to congratulate to my friends for this very wonderful meeting. My previous Evgeny Vadim, очень приятно снова видеть вас. And very interesting presentation from Fabrizio. Thank you very much. And my question is that you described that you recognize the guidelines of the leading countries as valid, but for the adequate using in practice problems are in your possibilities. What kind of possibilities, limitations are the main problems, like education, reimbursement, general regulations, or other? Thank you very much.
Okay, if I should answer your question very fast, I would say that all of them. They are all a problem. They are all a problem because, as I said before, I have a situation here in my private practice where I am right now. So this is something that I can prescribe whatever I want, and I can talk to the patients about the costs about it. When I'm in the public health system here with my residents, we need to adapt the situation. Sometimes we prescribe graduated compression stockings and the patient tells us, oh, I have no money for that. So we need to adapt whatever situation. So this is something that it needs to be adapted according to local reality, depending on where you are.
Thank you so much, Fabricio. Thank you so much, Professor Shaglov and Professor Lazarashvili. We fly all the way to Central America now, introducing Professor Lorena Grillo, a wonderful person, again, a great organizer of the FLEBO-LATAM, another meeting like the St. Petersburg Venous Forum. I highly suggest you to attend. I will share now the screen with her talk, and we will enjoy her live later on.
Good morning, everyone. My name is Dr. Lorena Grillo from San Jose, Costa Rica, and I want to thank you for the invitation to participate in the St. Petersburg Venous Forum. I'm going to talk to you about venoactive drugs, the LATAM and international guidelines comparison. This is a very interesting topic because venoactive drugs are so updated and highly used all around the world. And we can see that we have different guidelines with different analyzing methods. Also, for ulcers, we have different guidelines and different analyzing methods. As we can see in the global, we have a pentaxephyllin level A, and in the LATAM 2016, we have a 2B grading. We have MPFF with an A grading from global and a LATAM grading of 1B, with Solodexide A grading for global and a recommended without grading from the LATAM guidelines. We have different data regarding venoactive drugs on chronic venous disease, like the one we have on 2017 review on MPFF, which showed useful in ulcer healing and reducing the symptoms of chronic venous disease, in which we were able to address the effects of MPFF in basic mechanisms of chronic venous disease, like cascades of inflammatory molecules that are released, maintaining the inflammatory state and upregulating the factors that correlate with capillary permeability, impaired lymphatic flow, and vascular proliferation. We also have the 2018 review on Solodexide, in which it shows a significant reduction in recurrence of venous thromboembolism after discontinuation of anticoagulation treatment. With the Cochrane on rhodocytes, it showed no supporting evidence in comparison with placebo in control of symptoms. Regarding the new data also that we have on the 2019 review on Solodexide, it pointed out a very important anti-inflammatory and antithrombotic action throughout all the CVD spectrum. In the 2018-2019 review on MPFF, it was supported by two reviews, one from global, one from LATAM, which showed usefulness in all 6 clinical classes of CVD. And regarding the recommendations of the medical management of chronic venous disease and the role of the MPFF, we can see that on the left side we have a normal venous pressure endothelium, not absolutely functional. And on the right side, we can see dysfunctional endothelium due to high pressure, as in chronic venous insufficiency, with white blood cells addition to the endothelium, which with the use of MPFF, we could have a protective tonic effect, augmenting the venous tone, augmenting the lymphatic drainage, and diminishing the capillary hyperpermeability and diminishing the venous stasis. With this other publication of Dr. Gabrielov in 2019, it showed effectiveness and safety of the MPFF in the treatment of varicose veins and of the pelvis and the lower extremity. And we could see that they had two different groups of doses. In both groups, we had very good results with a twofold reduction in pain, pelvic, perineal, and lower leg in the first month, and reduction in chronic pelvic pain also at 2 months. In the second group, we could see that there was a decrease in the chronic pelvic pain severity from 6.3 up to 1.2, also in the perineal and leg pain, which was also confirmed by radionuclide phlebography confirmation. Also, we have new data on venoactive drugs for ulcers, as it shows in the 2016 review, in which the thing is that we have a significant amount of literature that has a risk of bias of randomization, allocation, concealment, and also unblinding. But the only one that showed a significant effect as an adjunct of venous ulcer treatment was pentoxifylline at the dosage of 400 milligrams 3 times daily. It's important to say that it's yet unlicensed, and the ESVS recommends against it. In the 2016 Cochrane, venoactive drugs showed beneficial effects on symptoms, signs, and edema, like trophic changes, cramps, restless legs, and paresthesia, but showed no significant benefit in ulcer healing compared to placebo. Also, I wanted to end up with 3 ideas or messages that were posted in these global guidelines trends. And it's the impact of musculoskeletal and postural conditions, which potentially may mislead the patient-reported outcomes in terms of symptoms. Also, the potential of bias of psychological component, together with the wide range of symptoms and the quality of life report. I think it's important also to be able to explore the correlation of venoactive drugs and hemodynamics changes, which will provide maybe better understanding of the biosignaling and its related impact in chronic venous disease. Thank you very much for your attention.
And we deeply thank Professor Lorena Grillo, and we now introduce the Russian colleague. Eugene, the mic is for you.
My pleasure to introduce Professor Bogachev Vadim from Moscow, one of the leaders of phlebology in Russia.
Sergio, Lorena, thank you very much for invitation to take part in the discussion. Lorena, thank you very much for a very interesting presentation, but my question is about the significant discrepancies between level of recommendation for the same venotonics in the different national guidelines. It's look like that criteria of evidence-based medicine work very bad, or work specifically for nationality of the recommendation. Can you comment the situation?
Professor Grillo?
Thank you, Doctor, for your question. It's very interesting, and I think we have addressed it in different topics now. And I think the good thing about being able to standardize is that it doesn't mean that the studies we have are not objective, but they're not standardized. But we need to know how to be able to appeal to all the different data that we already have in order to be able to make the best decision for our patients. But I think there's also always a difference between our countries, and it's a reality.
Thank you so much, Professor Bogachev and Lorena. It's now my honor to introduce all the way from Spain, Professor Rodrigo Rial, one of the biggest figure around the world and with a specific expertise also on this topic. So, Rodrigo, the mic is for you.
Hello, good evening, everybody. I am really feel very honored to be here with such faculty. Well, this is a very, very good presentation. Congratulations. Felicidades, Lorena. It's a very interesting presentation. In my opinion, venoactive drugs are not comparable since they are different in their mechanism of action. Sulfonyl is an antithrombotic drug, and they should be studying different drugs for the same disease. I think that beyond any doubt, the classical venoactive drugs are useful in any stage of the chronic venous disease. And Slovexis has a role in ulcers, but I think it must be investigated for initial stage deeper of the chronic venous disease. What's your opinion about this, Lorena? We must split the analysis of these two drugs.
Lorena?
I think we are not exactly comparing the drugs to each other, but I think it's so acute what you're pointing out. And it's that we need more evidence, and we need more evidence in the early stages with the different venoactive drugs that we have now. And also very important to be able to measure in an objective and a standardized way the outcome measures, and also taking in consideration psychological components that could represent a potential bias when we do our research of the data and how we put our parameters. But definitely, I think I thank you very much for your comment, and I think we have a lot more investigation to do. Thank you.
Thank you so much, Professor Bogachev and Professor Rial and Professor Lorena. I thank you also, Eugene, for asking me to talk now about this topic, non-thermal and non-tumescent in the venous treatment. Is it time to stop the fire? And indeed, this session will finish with the honorary lecture of Professor Shaidakov on the new NTNT possibilities. These are my conflicts of interest. I have to say that it was extremely interesting to co-work with many friends and colleagues from all around the world, including many Russian friends who are here today on the document you can find published on phlebology, indeed on similarities and controversies on guidelines. And as you can see, you can find 11 chapters in that 65 pages document, one of which is dedicated to endovenous saphenous ablation and the related guidelines we explored. You will find many graphs like these ones that are showing us how much we agree or not around the world and along the time in the grade of recommendations. And I would have to say that we agree that thermal tumescent is the main indication for the great saphenous vein. And we could also talk about the small saphenous vein that is a different in reality chapter. We know that then thermal tumescent is approved by the guidelines, it is mini-invasive and it is fast, but there are also colleagues and literature showing us that tumescence could bother, even if I have to say that personally once you learn how to do that properly, it shouldn't bother that so much. It is rare, but it is possible to have thermal injuries. And of course, we should always look at the cost effectiveness and the time effectiveness of our procedure. We should also agree, I think, internationally on what we consider our primary endpoint, because we usually focus our guidelines on the occlusion rate, but we should also point out the importance not just of the anatomical success, but also of the impact on the quality of life and the cost effectiveness. This interesting paper by Bradbury is showing us, for example, that compared to ultrasound-guided foam sclerotherapy, thermal tumescent is better. but not in terms of clinical success and patients' reported outcome, and not in terms of morbidity and complication. They are the same. If we look at cost effectiveness, we could also find the data suggesting that it is less effective, even if we have other papers showing a different result. We know that sclerotherapy is appealing, but we also know that the occlusion rate along the years, of course, is failing. And we have also data similar to this in terms of symptom-free at 8 years. So we should improve a little bit, maybe this foam. And like for a good Italian pizza, the thickness could matter, meaning the thickness of the venous wall. And for this reason, indeed, now we are talking about mechanical-chemical ablation that is combining not just the improvement of the foam inside the wall, but also the spasm effect we are getting thanks to the device. As demonstrated by many studies, and of course also the Maradona investigation, it has been demonstrated that it is satisfying as procedure in terms of clinical outcomes, but with very short follow-ups, as you can see over here, with the best postoperative pain, a faster improvement of the VCSS score, but compared to radiofrequency, it has also more hyperpigmentation and more anatomical failures. If we compare MOCA with the endovenous laser ablation, again, we see similar results in terms of quality of life, a little bit better periprocedural pain, with more anatomical failure already at 1 year's follow-up. So we see that the game is still open. And indeed, if we look at 5 years results that have been recently published with MOCA, we see again the failing of the anatomical results with a still improved quality of life. We have also new tools coming into the market, even if it's actually not new, it has been in the market for quite a while. We have promising results, but again, at 24 months. So we have to look forward for longer follow-up and also not just for anatomical occlusion rates. Then we have all the chapter of the different glue available in the market. And Colluri showed us recently the possibility, again, at a very short follow-up, 6 months, of Venasil positioning as the best one among the 5 that were investigated as techniques, but Venasil was the only glue assessed in this investigation, with promising results also in terms of postoperative pain and adverse events. But if we are looking at the other quality of life, we see that the results is less satisfying compared to the other procedures you see reported over here. And we have data also with the other glue available in the market with promising results in terms of occlusion rate, but again, just short follow-up, a little bit longer in this one, with always the important topic of pointing out the possibility of the reactions to the foreign body and the possible creation of granulomas, as recently reported again in the literature. There have been some comparisons with glue and endovenous laser ablation that, as you can see, are basically repeating the results I've already reported before. This is a recently published analysis looking at 7 studies with the varicose glue. It is interesting to notice that we never report DVTs. It should be pointed out that maybe we should look more carefully, because it's really strange, in my opinion, that it's so rare to find DVTs. They're actually almost not reported, while we have a problem, as we know, with the superficial venous thrombosis, because the phlebitis could scale up from 2 to actually 20% of the cases. So again, all these topics are reported in the document. If we look at the guidelines internationally, we see that there are countries who are already including now mechanical chemical ablation, but we see that there is a huge heterogeneity, of course, around the world with the different approaches. If we look at the most recent guidelines, like the one of the European College of Phlebology, we see that thermal tumescent remains like the mainly indicated procedure, but we have the new procedure raising up in the field, so it will be interesting to see how the next years will go. And it is interesting to notice how the guidelines are aging fast, because, for example, as I was saying, in the European College of Phlebology guidelines, there were no data reported at 5 years for example, glue, but in reality, we have now the VCLOS trial showing the 5 years results of the glue, in particular Venasil, that is competitive with radiofrequency ablation in terms of occlusion rate. So to answer the question Professor Shaidakov gave me with this talk, is it time to stop the fire? I think in reality it's not. It's time to fight fake news, as reported in this paper that is reporting 40% of medical websites reporting fake news. So I think it's a little bit fake when they are trying to propose these new techniques, saying that it is cost effective, it is faster, with less pain, more office-based compared to the thermotumescent. I think we have to gather together once again, identifying what the best outcome for all of us is, also with the different nationality needs, agreeing on what is evidence-based and what is not, and what is fake news. And I take this chance to invite you to visit this website, where you can report in every language, including Cyrillic, Russian, eventually encountered medical fake news. I deeply thank your organization for being part of the world teamwork that will lead us to the creation of a Delphi consensus on this topic that will be presented in Dubai during the Expo. And I take this chance, of course, to deeply thank Professor Shaidakov, looking forward for being together, all together in Italy, in Russia, or somewhere in the world. Thank you. And now, Eugene, I will let you introduce the next top experts from Russia.
Sergei Gushkov from Russia, from Yaroslavl. He's absent. Unfortunately, he's ill, but everything is all right. He's under control. And Vadim Bogachev asked his question from Moscow.
Hello, Sergio.
Hi.
Now, I'm Oleg Gushkov. It's a sudden situation in Russia. I changed my name. My question for you, what do you prefer for yourself, a thermal or non-thermal ablation?
It's talking among friends, Vladimir. I think it is like asking if I prefer, what kind of dress I prefer when I get out from my house. It really depends where I'm going to. So my answer to you is that there are cases in which I'm extremely skeptical still in using non-thermal, non-tumescent, in particular if you're talking about glue. And of course, in case of ulcers, we know that there have been publications recently showing the safety profile of this, but we always have to consider that there is a foreign body. So my answer to you is, in all the situations in which I see that there is a risk of easy inflammation or hypersensitivity or whatever other contraindication to glue or side effects, I would go traditionally with thermal tumescence. There is a nice publication that just came out a few days ago from China, showing us that now we don't have to worry just about heat, but also about JIT, which is the endovenous, of course, glue-induced thrombosis. And interestingly, the only risk factor they found in that is a caliber of the GSV smaller than 5 millimeters. Now, we could start brainstorming if we really want to treat a less than 5 millimeter GSB, first of all. But assuming we want, I think we have now to take into consideration also new aspects. So I hope this answers your question, but I found them overlapping with some specific situations where contraindications are coming into the play, so I would go traditional with thermotumescent. Thank you so much for the question. And now it's my honor to introduce from Bulgaria, Professor Elena Goranova, a dear friend and a huge expert from Europe. Elena, your question?
Hello, my colleagues. Здравствуйте, друзья из России. Thank you, Sergio, for inviting me at this prestigious webinar. I appreciate your presentation very much. You have performed a great work to deeply analyze all available new methods so that everybody of us can make a considerable comparison. During the last 20 years, vascular experts from all over the world have been working for a better venous management. Our goals have always been high occlusion rate, no pain, good quality of life, cost efficiency. The European College of Phlebology guidelines recommend endovenous thermal ablation at first-time treatment for saphenous vein incompetence. However, the level of evidence within the different guidelines should be highlighted. Professor Giannisini's presentations is focused on the advantages of MOCA, VenaSeal, VenaBlock vein close as an alternative method to the thermal procedures. However, NTNT rely on synthetic materials and venous introduction. They bring some risk and inflammation or granuloma. Therefore, according to evidence-based data, we need to collect more investigation results and then produce conclusion which one is the best. Thank you.
Thank you, Elena. And indeed, I totally agree with you. And I tried to deliver the message that we have to agree, I think, in the future guidelines on what the primary endpoints for us are. And the anatomical occlusion rate, of course, is not just the only one. And the cost effectiveness will be extremely important, in my opinion, as well, of course, as patient-reported outcome. So as I also said before, I'm not in support of one rather than the other. I'm in support of a tailored procedure that is bringing not just innovations in techniques, but also in a strategy, because we should also talk about hemodynamics. So thank you so much for the questions. Thank you so much, Eugene, for involving me in this. And now I will introduce the lecture of Professor Chi, who is unable to join us because there is an emergency in his hospital going on, but we have all his recorded talks. So here we enjoy Professor Chi, and then we'll enjoy the discussion.
Hello, everyone. I am Willie Chi. I'm from the University of California at Davis, and I will be discussing the topic on med and unmet needs in modern phlebology. From the innovation standpoint, I want to thank the organizing committee and Dr. Shadakov, as well as the VWIM Foundation for this invitation. I do not have any disclosure related to this talk, but I will be discussing non-FDA approved devices. Now we'll go ahead and dive into both non-invasive and invasive management of phlebology, and I will spend more time on the invasive part. Now, when we're talking about non-invasive technology, we're really looking at different forms of compression therapy. Now, we're not going to discuss each and every single one, but as you can see that there are a variety of different compression methods, and it's been available over decades. Now, more recently, we have the compression wrap using Velcro devices that to address underlying vein issues, and then in concurrent with pumping or different type of compression pumps as well. In the middle of the picture is actually a non-medical device that appear to be serving medical function, and we're going to see more and more of that out in the near future, especially in the web space. Now, from the non-invasive end, I would say that the most pressing need for compression therapy is actually interface pressure measuring devices. Currently, we have 3 different forms of interface pressure measuring devices available: the PicoPress, the Kikuhaimi, and the Juzo device. All 3 of them rely on pneumatic pressure sensing, and I believe that that's one issue that really has to be addressed, that there has to be additional different type of sensor that that should be commercialized. Certainly piezo resistive sensor has been attempted, and in addition to that, wireless technology need to be applied, so we will make the device much less bulkier and much more portable and applicable. Now, from the invasive end, we could see that there are various forms of thermal and non-thermal technology. In front of you is the typical thermal technology, including laser, RF, steam device, as well as microwave. Now, as far as a non-thermal, non-tumescent technology, we do have the MOCA device available. Phlebograph is actually quite popular in Europe and Asia. We have the clear vein in the Americas. Certainly, the Tessari foam production method is very popular to all of us over years and years. BTG actually had made a canister termed Verithena, and BTG was acquired by Boston Scientific about 2 to 3 years ago. Now, furthermore, in terms of the non-tumescent, non-thermal devices, we do have 3 different type of cyanoacrylate glue that is available. VenaSeal from Medtronic, and we have 2 Turkish glues that are available. Now, as far as additional technology, that includes ScleroSafe, which is a US-based company using a very simple device with 2 syringes, and as you're injecting your foam, actually the vein would actually be cleared out first, meaning that there is a negative pressure to draw blood first before the foam is infused. ScleroSafe could certainly combine with V-Block, which is a stent that is placed at the proximal end of the great saphenous vein near the saphenofemoral junction. Last but not least, we do have the high-intensity focused ultrasound using external ultrasound beam to address underlying saphenous vein issues. Now, looking at the overall clinical data, comparing with the cyanoacrylate, RFA, and the laser therapy, you can see that there is certainly improvement in all from the standpoint of 24-month follow-up. Now, there has been more and more work done with deep vein repair. This is a picture of Dr. Omadi, Dr. Melati from Italy and his work. But deep vein repair is not something that is new. It certainly has been attempted back in the 1990s and then continue on in the 2000s through many different authorities throughout the world, including the Japanese, the Italians, the Americans, as well as the Chinese. This is a picture of a popliteal banding that came from Fu Wei Guo's group from Shanghai, China, looking at popliteal vein banding as a method to address venous hypertension. Certainly, the less invasive method of applying the banding phenomenon would be injecting something like cyanoacrylate and hyaluronic acid, not into the vein, but outside of the vein to compress the vein down. The work actually has been quite interesting and certainly started with Chris Ragg's, I would say, innovation back the early part of the decade. Now, let's not forget about the Chiva and asphalt methods, which are the saphenous sparing method in addressing underlying vein issues. Sergio Genesini certainly has attempted using thermal-based technology and using the Chiva principle to address the chronic venous insufficiency. Now, I believe Alan Davis actually put it best in the terms that do we need another modality for really truncal ablation or in the field of phlebology? And I like Alan's conclusion that we certainly need better and longer term follow-up to delineate the safety and efficacy of modality and ensure that the best treatment is tailored to the patient. So my thoughts on the topic is that there's always going to be innovation in the superficial and deep veins space. But more importantly, we need to have various form of education method to educate both the patient and the practitioners. We really need to dive into the cost effectiveness of treatment for patients, because certainly regional differences. A method that's great and affordable in the Americas certainly may not be available in the third world countries. So using the most cost-effective method to treat the right patient at the right time is really my final thought.
And we deeply thank Professor Chi. I'm always honored of being his friend and colleague, a huge figure from University of California, Davis. And now we have Eugene, our top experts from Russia, if you want to introduce us to him.
My pleasure to introduce Alexei Fokin from Chelyabinsk. He's a vice president of Angiology Society of Russia. Please, Alexei.
Thank you very much for best presentation, excellent presentation. I have one short question. What's your opinion about current place of direct oral anticoagulants in phlebology? Thank you very much.
Thank you so much, Professor Fokin. And as I was saying, Professor Chi is currently in an emergency situation with COVID, unfortunately. So here is his answer.
Hello, everyone. I want to thank Dr. Alexa Fokin's question on the current place of DOAC in modern phlebology. And we're all are familiar with DOAC. And to me personally, I believe that it is one of the biggest inventions in the last, I would say, a few decades. In the past, all we had was warfarin, if not low molecular heparin agents, but now we have DOACs that are available as oral agents that you do not need to be monitored, and they stay quite active and stable and effective within the system. There are a number of different antidotes to DOACs in the case of bleeding, which I'm not going to go over in detail. But to me personally, I believe that DOAC is becoming the standard of care, primarily for a venous patient, but certainly it's also applicable for our peripheral arterial patients as well. And I hope this answers your question. Thank you.
Thank you so much, Professor Falkin. And again, sorry if Professor Chi couldn't be here, but he's really in a difficult situation. So we look forward for the next chance to interact. Thank you very much. Thank you so much. And now it's my deep pleasure to introduce Professor Orrego Alvaro on the way from Chile. So Alvaro, if you are with us, could you please make your question?
Hello, everybody. Thank you very much, Sergio, for inviting me to this amazing activity. And I have a couple of short questions for Dr. T. First of all, I prepared 2 questions. First, how do you explain having lesser VCSS after 2 years in the group treated with saccharylate if the treatment goal was the same, the occlusion of the great saphenous vein? And we know the recanalization is the same. How can you explain the different VCSS if the procedure is the same? First of all. And second, nowadays we have low recanalization, no pain. If you have pain, you have problems with your procedure, with TT, etc. In your opinion, what is the improvable in the future? Maybe will the cost be? Thank you very much. And congratulations for your talk.
Thank you so much, Professor Reagan. Here is the question of Professor and the answer of Professor Chi.
Hi, I want to respond to Dr. Orrego's question. His first question is, how do you explain having lesser VCSS after 2 years in the group treated with cyanoacrylate if the treatment goal was the same, the occlusion of the GSV? I'm not sure if I can answer this question correctly, but if you were to dig into that particular paper published in 2018, that about 15% of patients in the RFA group and 21% of patients in the EVLT group did not have appropriate follow-up. And those are significant numbers. Now, what is the number of the cyanoacrylate group that did not follow? It's only 4%. So I believe that we could explain it in a couple of ways. Number one is, I think that statistically, there is certainly a big difference simply because of the number of follow-ups. There were more of the cyanoacrylate group that did follow up as compared with the thermoablation group. Now, you could argue that that similar VCSS improvement is seen in the thermal group, but certainly the cyanoacrylate group had a better VCSS score. The other way of looking at this is that I am not sure if the finding could be generalized or could be reassured. And if you were to look at Nick Morrison's most recent publication in Journal of Vascular Surgery, Venous Lymphatics, that's the 16-month follow-up of the V-CLOSE trial, that looking at VCSS comparing the RFA with the cyanoacrylate group, that the p-value was not significant in each, comparing the groups. Obviously, there is certainly improvement in VCSS in both groups from the initiation of the procedure to the 16-month follow-up. Now, the same is actually true for also both generic and venous specific questionnaires such as AVVQ, and they use the EuroQoL 5D5L and AVVQ as two of the measuring methods in the in Nick Morrison's paper. And again, there's no difference between the cyanoacrylate group or between the cyanoacrylate and the thermoablation group. The second question of Dr. Rego is, nowadays we have low recanalization, safety, no pain treatment. In your opinion, what is improvable in the future? That's a million-dollar question. I believe that although we have very good tools nowadays, but now is the time to look into, I would say, population specific cost effectiveness. And one perfect example is, let's say, for example, the cyanoacrylate group, which based on publication, the hypersensitivity rate could be in upwards of 9%. Now, does it happen in, is it generalizable to multiple population with different ethnicities, or is it only applicable to the Western society? That remains to be seen. But I believe that there may be a genetic difference in terms of the different methods we currently have available in managing patients. So we have to take account into that. And that is besides the point of the main theme of my talk, is that the cost effectiveness is actually very important in terms of how we're managing our vein patients in the future in terms of affordability. And with that, thank you all.
And we deeply thank Professor Orrego and Professor Focking and Willie for providing another lecture, basically. So it's now my huge pleasure and honor to invite our host, Professor Shaidakov himself, to take the floor and deliver his honorary lecture on glue in chronic venous disease treatment, state of the art and future direction. So, Jean?
Thank you very much, Sergio. It's my pleasure to introduce glue in chronic venous disease treatment and introduce a new Russian glue technique. Within the last 2 decades, the treatment of incompetent truncal veins was revolutionized by the introduction of minimally invasive endovenous thermal ablation techniques, which led to excellent long-term anatomical success rates. However, to apply thermal energy in its modality of provide local tumescent anesthesia, and in addition, heat-related complications such as skin burns, knife injury, and the thermal heat-induced thrombosis may occur. Within the last years, several new devices have been introduced which can be used without tumescent anesthesia and without application of heat, referred to as non-thermal, non-tumescent techniques. So one of new approach is the VenaSeal technique. VenaSeal venous closure device was developed by the company Safran in the United States in 2011, and in February now it's Medtronic property, you know. In February 2015, it was approved by the FDA for the permanent closure of lower extremity superficial truncal veins, such as the great saphenous veins, through endovascular embolization with coaptation. Over the years of clinical use, VenaSeal, United States, and VenaBlock, Turkish production, markets have been closely integrated to the everyday practice. Numerous works of the comparison with other endovascular methods of chronic vein disease treatment show that in terms of their anatomical target occlusion, they are not inferior for radiofrequency abliteration and laser methods of main superficial vein ablation. Certain discrepancies in the comparison with these rather similar chemical methods are primarily related to the viscosity of the adhesive substance used. The more viscous Turkish glue is criticized for faster polymerization with a potential higher possibility of its progression. In 2017, the VenaSeal vein occlusion system was registered in Russia, but during these years, this system has not been widely implement in clinical practice in Russia. And what the main problem? The main problem, of course, is the price. It's a cost. That is why we found it most interesting and relevant from a practical point of view to study the Russian development of glue composition and try to identify the most effective of them in order to implement in everyday phlebological practice. In Russia, alone over the past 10 years, more than 13 cyanoacrylate medical formulas have been synthesized. At the same time, there has been no data of the possibility of using glue composition for treatment of diseases of the main superficial veins. Having analyzed in detail all the Russian developments presented to date, we have come to the conclusion that the sulfacrylate adhesive compound, the patent for the beginning of 21st century, 2000, can be used as the potential occlusant for the no-thermal obliteration of varicose veins. The Russian adhesive sulfacrylate was synthesized in 2000 in Constanto. For foreign analogies, it is based on ethyl ester of alpha cyanoacrylate acids, not butyl. And butyl cyanoacrylate, phenacin and velablock, it's the same. And 2 additional plasticides were added to the glue, which reduced the brittleness of the compound while reducing the inflammatory reaction due to an additional substance. In 2010, it was registered and approved to use in Russia. The purpose of the study was clinical, instrumental, and morphological in vivo justification of efficiency and safety of the use of local products, sulfacrylate adhesive, for obliteration of varicose veins in the lower extremities of humans. From May 2019 till July 2020, and the basal catheter obliteration of the main trunks of the great saphenous vein and the small saphenous veins were performed using the sulfacrylate glue in 48 patients with varicose disease C2, C4. And diameter of the target vein varied from 9 to 13 millimeters. We evaluated pain, thrombophlebitis, local and general allergic reaction. Ultrasound control was carried out on the third 60 days and 6 months. Immediately after the intervention and on the first day, the possible spread of the glue in the proximal and distal direction of the great saphenous vein and small saphenous vein, as well as long the communication vein, was monitored. It's an ultrasound control the first day, and the 1 month you see the full occlusion of the vein. Histological study of morphological changes in vivo was performed with the consent of patients to conduct the study. We studied the parts of veins taken from 15 patients within the period from 7 to half hour after the introduction of the glue into the lumen of the vein. In 11 cases, superficial segment of great saphenous vein, and in 4 cases, small saphenous vein. Results. The main problem is the pain. Pain after 48 hours was observed in 28 patients, 58%. But VASH scores ranging from 0 to 2.2. In 6 cases, 12% patients reported moderated pain, score 4.5. Symptoms resolved after administering oral steroids and antihistamines. Post-procedural phlebitic reaction took place in 25% only, and self-limited inflammatory response over the treated vein, and no cases with classic superficial venous thrombosis. Results. There were no cases of glue extension into the deep veins, and no allergic reaction in the patients. In 6 patients, when the glue reached the subcutaneous fat, there were signs of aseptic inflammation that did not require any treatment. It's a morphological data 1 month, 3 and 5 months. And 2 months inflammation of 2 slices of wall, and 7 months the full occlusion of the vein. During the histological examination, starting from the 7 days, there was a gradually relieving aseptic inflammation of the vein wall. Within half hour, the lumen of all veins was completely obliterated by mature connective tissue. In the absence of glue particles, which was indicated it's complete biodegradation. It's a little mistake, not complete biodegradation. Of course, it's our dream. Biodegradation. The anatomical success rate was 100 after respectively 3 months and 6 months follow-up. Developed in Russia, sulfacrylate glue has even lower viscosity and higher fluidity, approaching the water fluidity or more precisely a thin syrup quality. At first glance, in connection with these qualities, one should have expect when the polymerization capacity of the Russian glue and potential reduce adhesions with this possibility of more prolonged advancement in the deep vein system, causing potential embolization. However, the fundamentally new formula of sulfacrylate, alpha-senacrylatic acid diethyl ether, which included 2 additional plasticides to reduce beadlessness of the extraction and an additional all substance to increase adhesiveness of the glue composition, enabled to avoid the potential complications. While following the glue injection technique, we did not observe the problem on glue setting in the delivery system. Extremely high adhesive properties of the glue together with its low viscosity and elasticity allowed avoiding problems with the possible advancement of glue into the deep vein system. Conclusion. Thianocrylate adhesive embolization of incompetent truncal veins using the Russian glue thianocrylate is a safe and efficacious procedure. The high adhesive ability of the glue contributes to the absence of extension into the deep system. The glue is biodegradable. The Russian glue is a low-cost treatment which can easily be performed as an office-based procedure. Thank you very much for your attention.
Thank you so much, Eugene, and indeed it is the honorary lecture, so you have the honor of the lecture, but also now the responsibility of answering to 3 huge professional figures, starting from Professor Mo Makoto from Yokohama University. Here is his question, even if he's with us live, so we'll enjoy also his presence live.
Spasiba, Professor Shaidakov. You performed a histological examination in 15 patients and demonstrate absence of glue particle, which was indicative of its complete biodegradation. Recent study, glue is present even after 5 years, and most other studies indicate permanence of the cyanoacrylate implant.
Thank you very much.
Here is the question. How many cases did you observe disappearance of the glue out of the 15 cases? Does your specimen examine by continuous cut method? Thank you, Professor Shaidakov.
And we deeply thank Professor Makoto, who is with us in this moment. I see him there.
Thank you very much, Mo. I don't like the phrase, thank you for interesting question, because all questions are very, very interesting. It's very important questions. And the main question about the biodegradation of the new glue. Of course, it's you understand this is rather difficult to investigate the patient after half a year of the operation with the full success, clinical success. And we investigate, of course, no 15 cases after half a year after operation. Only 3 cases and only 3 patients, and it was the little pieces of the vein, ½ centimeters, and it was not continuous cut method, unfortunately. Unfortunately, because we don't have insurance of the mistakes of our morphologist colleagues, how to, with the technical details. So it's not continuous cut. It was 5 fragments, 5 slides of the vein after 5 years of implantation of the new glue. So in 70% cases, we don't see the glue inside the vein, but in 30% we see not a full glue, but a lot of small parts of the glue. So we can say about the biodegradation, not a full biodegradation and not a complete biodegradation, of course. Thank you very much.
Thank you so much. And Professor Mo, are you fine? Any other comment from you?
I'm fine, but the historical examination after procedure is very important and difficult procedure. So this is a very nice study. Thank you very much.
Thank you so much. And as I said, you have not 2, but 3, since you are the honorary lecturer. And indeed, it's the huge figure, of course, in this case from Poland, of Professor Urbanek Thomas, making the next question. Thomas?
Thank you very much, Evgeny, for this very nice and interesting talk. It's pity that we cannot see us this year in person, but hopefully it will be possible soon. Evgeny, I think that it's a very important progress looking for the best method for varicose veins treatment. I have the practical question to you regarding the procedure performance, because you mentioned about about the compound, about the cyanoacrylate as a low viscosity compound. So my question is, what's the distance from the deep vein where you start the procedure? How you monitor the pullback technique? And can we use this compound cyanoacrylate with the same catheter for the several veins, or it's just a single use? Because from the also commercial point of view and physician application point of view, there are the question that are always raised when we compare, for example, Venasil with the Turkish glue. So what's the technique when you use the Russian glue?
Thank you very much, Thomas. It's a real practical questions. It's a difference between American and Turkish glue, because the Russian glue, it's very, very liquid, like syrup, like water. So the distance from the saphenofemoral junction usually 2-3 centimeters, but assistant compress the femoral junction before the use glue. We don't use the gun because it's a liquid form. We don't need the gun for implantation of the glue. So we use the continuous pullback method. And only 1 milliliter we need for close the whole vein and the femoral vein. So femoral segment. It's a manual and visual control and the ultrasound control. It's a different technique, very quickly technique, but it's a different. And at first patients we studied, it was very difficult to start, but we did it. Thank you.
Thank you so much, Professor Urbanek and Eugene.
Thank you. Thank you.
And now we fly all the way to China with Professor Jinsong Wang and her question. Jinsong, are you with us? Yes.
Yes. Thank you, Sergio. And congratulations on Professor Shatkavar's new glue in Russia and to reduce the cost. And looks it is very promising. So I want to ask the question, like, I mean, what's the ideal perfect glue chronic venous, for greatest venous vein? And what's your perspective, how to improve the quality of the glue? Thank you.
Thank you very much, Jin Song. We don't have the ideal method to treat our superficial veins. So the main problem of the Russian glue and the glue in United States and the Turkish glue is the pain. And we really understand that it's aggressive glue to the venous wall. So it's a very important problem, and we try to improve our glue, of course. We started a couple years ago, but now we understand we need to decrease the pain. So we work with our colleagues from one of Siberia Institute from Novosibirsk to improve the quality of this glue and to decrease the complication like pain we have now in our patients. Thank you very much.
Thank you so much to Professor Wang and Eugene. And now it's the time of the wrap-up, and we couldn't identify a bigger figure than Professor Fedor Lurie. Is always a good omen for the Win Foundation to get started or to conclude big with the Fedor. So no need of introduction, University of Michigan and head of the Jobs Vascular Institute. Fedor, if you want to share your screen, I know you also prepared some slides.
Thank you, Sergio, and I will start with поздравляю Евгений, Вадим, всех участников конференции с огромным успехом. Два аспекта этой конференции были особенно для меня привлекательны. Это первое, это участие аудитории. Хотелось бы побольше, конечно, чтобы они обсуждали, не только вопросы задавали, но и также выбор темы. I'll switch to English now, Sergio.
Thank you, because everybody got crazy now. They couldn't know what to do. So go English, please. Thank you.
Yeah, I will. Let me just
Our Russian is a little bit rusty in these days, so.
На каком языке уже говорить, да?
Okay, guys, if you want to finish by yourselves, we just go home.
I hope that you can see my screen. I think that the selection of topic was especially...
We cannot see your screen, so let's ask for technical support. Are you sharing your screen, Fedor?
I am. Let me just... yeah,
maybe you have two monitors, so...
I'm gonna share
choose,
right
yeah, now, yes.
You can see it now.
Yes, go.
Perfect.
Go full presentation.
So I was putting my slides as I was listening to this fantastic session. And I think what I would like to reflect and summarize is the issue of the guidelines. You all remember a time when we didn't really have a system for grading evidence. Well, now we have it, and that's how the guidelines recently were developed, but we also have a system for grading guidelines, and I just encourage all of you to take a look at this update for AGREE-2 instrument, how to look at the guidelines. There are a couple of interesting things. If you look at domains, scope and purpose, every guideline has its own audience. And you here in this conference, most of you are experts, and the guidelines are not for you. The guidelines are for other people. Your participation in guidelines is different. But the other aspect of the guidelines, which I think was emphasized on this conference, is applicability. And each guidelines has the specific application. And I just want to just use one guideline from the American Venous Forum as an example, because it was referred. You know, what is this guideline is not just use of compression after interventions. It's what use the compression for. And you can see the highlighted, it's very specific. The use of compression therapy for example, improving outcome, decreasing pain, and so forth. It's not a general use of compression. There are many other reasons when you should or should not use compression after therapy. So the guidelines are very specific. Now, as experts in this audience, and you illustrated it extremely well through the program, here is what actually happened is the guidelines reflect the standard of care. And as you practice, especially when you have a substantial practice in this area, your clinical observations bring up some questions that are not addressed in guidelines, some contradictions, and that is where research and innovation comes in. Evgeny, your presentation was here. Other people presented exactly the same. Come with a solution, create the evidence, change the guidelines. This cycle takes time, and your participation is exactly here: questions, research, solutions. Not the following guidelines. This is what the result is. Unfortunately, there is another thing here which is specific to the countries and the policies, because everyone practices in a specific environment, and economically, drug availability, device availability, all these things affect how you practice, and they all reflect in the specific guidelines. This is why guidelines are very frequently regional. However, I, again, would like to really, and I'm not sure whether I exit the...
Yes, you exit. We still see your desktop.
All right. So you can unshare my screen if you can from there.
I can't. The technical part has to do that. So please, technical part from Russia, do that, or Fedor has to stop.
Okay. Great. And I just want once again congratulate all the organizers of this conference. I think it's extremely important topic and it needs to be addressed in more details. Thank you very much for opportunity to address this audience. Спасибо огромное, Евгений. Не смог физически, то есть не присутствовал, конечно, там хорошо бы мне быть в Санкт-Петербурге сейчас, а не здесь в своем офисе, но тем не менее огромное вам спасибо. Thank you very much for it.
And thank you indeed is the word that we say to all the faculty, in particular the Russian friends who join us in this one-to-one effort. It has been always a teamwork. You see from the social times in Cortina with Professor Shaidakov skiing with us, sliding on the guidelines like we did in this document, but also looking at something like new as we are doing now with the fake news. As I said, I look forward for co-working on together for the huge opportunity provided by the Universal Expo in Dubai. And of course, the first thing we look forward is to gather together again in person for this precious social moment. I then pass the mic and I'm off from now to Eugene and then to all the chairs of the session. Eugene?
Thank you very much. Thank you very much, dear friends, to take part in this St. Petersbourg Venous Forum in winter St. Petersburg before Christmas. So we have a Christmas meeting, you know. It was a comprehensible program for me and for all participants. You know that we organized this year hybrid meeting, so the 100 participants in different halls here in St. Petersburg discuss and met, and today we will have a gala dinner in one of the restaurants of St. Petersburg. So unfortunately, without you, without the leaders of phlebology in the world. Next year, I'm sure, I would like to invite all of you to St. Petersburg to discuss and to see St. Petersburg, one of the beautiful cities in the world. Thank you very much, all of you.
Thank you so much, Eugene. And we take the chance that Pauline is still with us. So Pauline, would you like to say just a quick hi from the airport?
Sure. Well, thank you very much again for inviting me to participate, Evgeny. It was a great meeting and I congratulate all the presenters. I'm very happy to see that the rapidly evolving technology can offer multiple avenues and options to our patients. Of course, it's very important to use the strong evidence when possible. And most important, I think, is to collaborate with our colleagues that are working in different clinical settings and share experience. Thank you again, Evgeny and Sergio and Oscar and Willie. And see you next year in St. Petersburg. I've never been there, and I'll be so happy to go all the way to Russia.
Thank you so much.
Thank you again.
Thank you so much, Cleopatra of phlebology, Wasila from Egypt. A quick closing hi.
Thank you, Sergio. I'm deeply thankful for such a great opportunity, really. It was an awesome initiative gathering together for more homogeneous international guidelines, including our dear continent, Africa. Thank you so much. And looking forward for another educational initiative now prepared in the backstage with the North Africa, with the Near Europe, with Professor Zaza Lazarashvili, called NENA, and hopefully it will take light very soon. Thank you again, BWIN Foundation, now family, thank you very much. Thank you, Professor Shaidakov, for such kind invitation, and spasiba.
Professor Bottini, on behalf of BWIN, thanking the St. Petersburg Venous Forum.
We need more time for this, for many topics. And topics of real interest have been addressed. I especially congratulate the speaker and panelists for such a brilliant discussion and a great closing by Professor Lurie. I have always thought that the important thing in our passage through life is to learn how to build and transmit culture. Only in this way we'll live a better society. Today is exactly what we have helped to achieve. Thank you very much again, Sergio and Eugenie, and thank you very much all friends, and see you soon.
And indeed, thank you so much, Eugene, and all the Russian friends in the St. Petersburg Venous Forum. Just have a glass of vodka for us tonight during the gala dinner. Okay? Make a toast for us. Ciao. Bye.